presentation, Dr. Salifu, on type 2 diabetes from Downstate. We welcome you. We're happy to have you here today.
Good morning, and thank you very much for the invite. I appreciate that. I have Dr. Dreisen in the committee, so I want to acknowledge him because he really did play a significant role in how we conceptualized the program and then deployed the program at Downstate. So thank you, Dr. Dreisen. So I'm the chair of medicine and at Downstate, and I oversee about 13 academic programs. That means internal medicine residency and various kinds of fellowships. I'm also the chief of the division of nephrology, which is kidney diseases. So as you can see, my interest, spans from hypertension, diabetes, and those kinds of metabolic issues. So when this ECRIP Center Award was announced, I became very interested. I said, we have to do something that reflects the institutional, problems and trying to address health disparities as well. As a segue, I also direct the Brooklyn Health Disparities Center, which is funded through the NIH for the last 15 years. We've been continuously been funded. So I thought this was a great program to house it in the Brooklyn Health Disparities Center and do something that is metabolic and that really addresses the patient needs of our population. So that was the background. So the overarching goal was, for this Center Award, was to provide clinical and translational research training for qualified GME candidates. We call them ECRIP Fellows, and to mentor them to develop into junior faculty and future independent investigators. By the end of the 2-year period, the fellows participated in developing data collection tools. They learned the needed skills for research. They inputted data and managed data. They learned statistical analysis of data. They learned to summarize data in abstracts and learned to write grants and papers. That was the goal, and I think we were able to achieve it, and I'll be able to illustrate that to you as we move along. This was accomplished through structured didactics and conducting a research project in diabetes to determine the role of novel cardiovascular biomarkers as predictive of the high prevalence of cardiovascular and kidney disease in patients of African descent. Now, this issue of diabetes is very prevalent in patients of African descent. I don't think that is surprising to anyone. And in central Brooklyn particularly, it's a big problem. 1 in 3 persons on the street in central Brooklyn actually has glucose intolerance, some form of glucose intolerance. And about maybe 16% actually have a diagnosis of diabetes. So it's a very prevalent problem in central Brooklyn. And if we could get something that understood some of the very fine details of the population, it will help in future guideline development by those who make the guidelines. But particularly we chose the topic because it represented a very strategically important growth area for the institution. I was already doing diabetes research in kidney diseases. A lot of my other colleagues in endocrinology, cardiology are also doing research in the area. So we thought that if we found a mechanism to tie all the pieces, all the various divisions and programs together, we could have a center grant. So that was the main focus. So we were lucky because we had a very nice, recruitment for fellows. We had 5 fellows, and 2 of them were 3 of them were assistant professors already in 3 divisions, and then 2 were GME residents who took 2 years off to do this research. So this is how we, planned the whole sequence of events. So the first one was didactics. So the didactics was over a 2-year period. So when we started in July of 2015, it coincided with the summer, and in summer of every year at Downstate, we have an intensive summer training program for research. We have actually a grant that does that from the NIH. So we recruited the 5 candidates to the existing program for 2 weeks. And the program director is Mohamed Boujidier. We had faculty from various disciplines in diabetes, endocrinology, cardiovascular, physiology, heart, kidney, HIV, statistics, epidemiology, cell biology. These were the faculty members that taught the courses in the 2 weeks. But it was very intense. And the goal is that we give them this intensive research training for the 2 weeks in July of year 1, and then they come back in year 2. By the time they come back in year 2, they are ready to actually write a proposal. That's the goal. But for this particular program, for the ECRIP, so the ECRIP fellows joined this program, and they were able to finish the 2 weeks. And then also in the fall, we have, from the School of Medicine, 18 different sessions of statistical methods. We made them join the School of Medicine's statistical program, and they were able to complete those 18 sessions as well. And then in year 2, we had them join the School of Public Health, the biostatistics and epidemiology, called the entire SIMS, that they joined them as well. So by the time they finished the 2 years, they had all these incredible amounts of research methodology, research training, and all the stuff, and they were well equipped to be able to handle research in a way that is they've never done before. So that is the didactics. The clinical research included, we designed a pilot project. It was cross-sectional pilot project in patients with type 2 diabetes, looking at novel risk factors. That was the goal. In other words, were there certain things in this patient population that is so different from the rest of the general population that we could detect and be able to study them more closely, especially patients of African descent, Afro-Caribbeans, African Americans, and African Africans. So the sites where, we got patients from diabetes clinics, cardiac clinics, HIV and renal clinics, both at University Hospital of Brooklyn and also at Kings County Hospital. Of course, you get consent before you talk to these patients. You review their charts and see who is willing to participate, and we get the consent and let them participate in the study. There is a whole demographic and review, including the clinical characteristic that is taking, and then the fellows took 10 ml of blood and then sent to the lab. That's my lab. I run an active lab, and then another doctor called Dr. Hussein, his lab for storage for the subsequent studies. And then they were also scheduled for physiologic testing for subclinical cardiovascular markers in another person's lab, Dr. Lazar's lab. So that's the clinical side. Now the translational side. So as I said, SUNY Downstate serves mostly an African American patient population with a heavy load of type 2 diabetes and cardiovascular disease and renal disease. But the guidelines in defining the risk factors for this population is really based on what we know in Caucasian populations. But we also know that there might also be subtle differences, even within the African American population. There might be subtle differences between the various ethnic groups in that population, which nobody has studied before. The other thing is that when diabetes sets in and there's a risk for cardiovascular disease, it tends to actually be more of a problem with kidney disease than with heart disease. So most of the studies have shown that diabetes actually damages the kidney more than it damages the heart. And that is actually evident clinically. We see a lot of patients with ESRD in Central Brooklyn than we see in the rest of the state. For instance, there are about 27,000 dialysis patients in New York State, and about 8,000 of them are in Brooklyn alone. So that is a huge problem already. And also the use of A1C, hemoglobin A1C, in African Americans is a problem because African Americans tend to have a higher A1C than whites. So how all these things play into risk factors and progression of disease is unclear, and that was the rationale for the study. So one of the hypotheses was that the glucose, the sugar in the patient's blood, how that sugar is modified could be different between African Americans and Caucasians. We call that glycation, the sugar itself. And then there are other things that also are also in the patient's blood. We have lipoproteins and other proteins in the patient's blood. We believe that the same glycation process and nitration process may also be altering these proteins in these patients that we could detect, and if we could detect, could make it to guideline development. So the lipid abnormalities in these patients are usually the total cholesterol, the total LDL, the HDL, and some of the other proteins that I don't need to go into details about. But these proteins that carry the cholesterol particles have differences in the way they are modified. So we call them modified lipoproteins. So how they are modified, we don't know the differences. Whether they are more modified in African Americans or less modified, we don't know the differences. And these issues have never been studied. These are all novel ideas that have never been studied in any literature. It's also possible that there are some vascular markers that we could detect, which could also differentiate between African Americans and Caucasians. One of the proteins is called F11R receptor. This was a receptor that myself and my group actually sequenced and cloned, and that receptor actually belongs to our portfolio. It's a vascular endothelial risk marker and allows the platelets to adhere to the vessel wall. We don't know how that actually is different between Caucasians and whites. And there's another protein called annexin 2. Annexin 2 prevents clot formation and allows the blood to be thin. So when annexin 2 is defective or is glycated, that is, it's modified, then it prevents the blood from being thin. The blood becomes thicker, so it reduces the ability of the blood to be thin, and therefore clot formation is possible. And there could be differences again in that molecule. Then there are genetic risk markers. I'm sure you've all heard about this protein. For some of you who are in the sciences, this is the basis of a new cholesterol pill. It's called PCSK9. When there is a mutation in this molecule, the cells are unable to prevent the cholesterol from getting into the cells. So a lot of cholesterol rushes into the cells, and then that causes atherosclerosis. Now, how this molecule is different from the expression of this molecule is different between African Americans and Caucasians is very difficult to tell, and there hasn't been any studies to show that. And then we also plan cardiovascular physiology markers, looking at how the blood vessels change when you stress them out. We call them carotid intima, medial thickness, pulse wave, and endothelial function, measured by different ways. So basically, what we're trying to do is, of all these novel risk factors, are there any differences between blacks or African Americans or patients of African descent and whites that we can do additional studies that would make it to guideline to better care for these patients? So this is the ECRIP laboratory. That is my lab. We expanded to include all the ECRIP fellows, and you can see here we got the Best Poster Award from the American College of Cardiology. That was presented last year. But let me show you some of the results. This is one of the papers comparing the variables that were associated with large artery stiffness between blacks and whites, right? I don't have to go to the detail. I just want to give you some summaries. By the way, we had 8 abstracts accepted to national meetings as a result of the ECRIP award. And so we're very proud of the fellows. They did a lot of work to get those abstracts out there. Anyway, this is a very important observation that says that among African American patients with diabetes, the large artery stiffness is independently associated with age and female gender, renal function, waist circumference, but not with poor glycemic control, which is what I said in the beginning. There was another abstract here that showed that among African Americans with diabetes, the microvascular dysfunction, the small vessel disease, is independently correlated with large artery stiffness. So if you're able to detect the small vessel dysfunction, actually that is predictive of large arterial disease in the future. And this is the letter we got from the American College of Cardiology commending us on this abstract. It was very important that for the fellow who actually did this presentation, and it was the best poster in the vascular medicine pathway. And this is the actual poster. It was talking about some of the modified proteins like annexin 2. Once annexin 2 is modified, again, annexin 2 prevents the blood from clotting. So if the blood clots, there's a preponderance of atherosclerosis. So the fellow was able to determine that the circulating annexin 2, but not annexin 5, is associated with development of subclinical microvascular dysfunction in diabetic patients of African descent, of course. This is significant finding because this has never been shown before. And now we know that this protein has something to do with microvascular dysfunction. And because microvascular dysfunction is related to macrovascular dysfunction, this is a very important finding because we can test for it. The other protein is the PCSK9. The levels were significantly correlated with subclinical macrovascular changes, which is basically exactly the same finding as the prior protein. This is another abstract looking at the modification of lipoproteins that found basically exactly the same thing. So all the novel risk factors that we were thinking about, a lot of them were correlating with microvascular and macrovascular disease in this population. This is another modification of the HDL that shows the same thing. This is another abstract that shows that oxidized LDL offer better predictive value. But you see, again, this oxidized LDL is not tested routinely. So this is the first time that we are trying to get this optimized. And again, if we're able to prove that in a bigger study, oxidized LDL could be something that you can measure to determine whether you can use that as a marker for a biomarker for macrovascular disease in patients of African descent. And again, another one looking at the macrovascular function, showing that it was positive. So we had altogether 8 abstracts, 1 won a national competition, and all those abstracts are being written up right now. So let me go through the successes and some of the challenges that we faced. Of course, this was an interprofessional team approach. Each team member was highly qualified and played their role well. We built up on our strengths, which is diabetes and working in Central Brooklyn. We approached a lot of patients for the study, and very few patients actually refused to participate. So this was really rewarding because a lot of the time we tend to think that patients of African descent don't want to participate in clinical trials, but this was the opposite. Everybody we approached, most of them, I would say 99% of them said okay. They didn't say no to the clinical trial, so that's really good news. Now the didactics was very successful. They had a 2-week in July. They had 4 months in the fall and in the spring. And then they had another round of a full semester in the summer of the following year through the School of Public Health. It was really a success. And when I'm talking to the fellows right now, it looks like I'm talking to my colleagues. They know the stuff, the research methodology and everything. They can really tear down a database and put it into perspective in such a way that I'm just impressed as I speak right now. The infrastructure that we developed to run the entire ECRIP program is still alive. It didn't die. Of course, the advantage is that I'm the chair of medicine, so I can fund it independently. But at least it gave us the boost to begin to put that structure in place to allow more people to participate. So even though the program is finished, I actually have residents who are doing research using the exact same infrastructure for the program. Now, 2 of the ECRIP fellows gained entry. Those 2 fellows who took time off from GME to do the study, they actually, as a result of this program, got cardiology fellowship. So I think that is a great thing. And then one of junior faculty members became an associate professor of medicine. And I think that's also a great thing. The other 2 junior faculty members, they are still at the rank of assistant professor, but they are now well equipped. I'm almost certain that in the next 2 years, they will also be promoted to associate professor of medicine because of what they've achieved in this program. The challenges, though, have to do with the fact that I think we're very ambitious in the beginning. We had, so much for the didactics, so much for the clinical stuff, and so many molecules to study. But at least we were able to study all of them, and it gave us a nice background to begin to develop programs upon those programs. We screened over 600 patients. Our target was 400 patients, but we got more than the target. But we finally got about 300 who were able to complete all the visits. It's very hard to get the patient to, some of them completed 2, but not the 3rd visit. But so I think that in retrospect, if we had planned all the visits in one visit, it would have been more successful. We would have had more people finishing all the study visits compared to what we had. But even then, the number is a big number. Now, maintaining the ECRIP structure is also a problem. I think if there is an ECRIP program collecting biospecimens, that becomes a big challenge, because after the 2 years, what happens to the biospecimen? We never thought about that when we were applying. It just happens that because of my position, we're able to find funding to continue the -80 freezers and the lab and make sure that there's somebody there watching them so that they don't spoil. But it is something that the ECRIP, the COGMI has to take into consideration, because after the 2 years, those samples are really precious samples and they shouldn't go to waste. So there has to be some sort of assurance in the application process of how to handle the biospecimens. So the future plans, basically to sustain the program the way it is, allow more GME residents to integrate into the program, continue to collect more data, and also to put the team together again and see whether we can approach the NIH and see whether we can expand this program. For instance, the work right now is all in patients of African descent, but I would have loved to do a comparison of these same biomarkers between blacks, patients of African descent, and maybe Latinos in the future. So that process ongoing. I have the team. We haven't submitted the grants yet, but I have the team, and we are hoping that we can submit a center grant through Downstate to make this happen. So again, thank you again for the invite, and I'll be happy to take some questions.
Beautiful presentation, wonderful work. Congratulations many times over. Questions from the group? Yeah. Stephen.
So 2 questions. One, did your physicians get a certificate for the work that they did on those 2 years that sort of marked their effort?
Absolutely.
Okay.
Yes.
Good. And I guess the other is a very hard question. But my question is, we work hard, we look hard to develop a recruitment strategy or a pipeline for people in science or academic medicine who are themselves underrepresented minorities. So I have a 2-part question. Were any of your fellows underrepresented minorities? And in the study of these large populations of African descent, is there a way that one can think about, even inter-institutional, developing residents and fellows who have a particular interest in this population to pursue academic pathways? Because that's a large problem that I think we all trying to address.
Yes. Well, let me answer the first part, which is how many of the fellows were minorities. 3 of the fellows were black. 2 of the junior faculty members were black, and 1 of the GME residents was also black. And then there was 1 Jewish colleague, and then another from Southeast Asia. So that was the breakdown. So it was well represented in terms of minority representation. And they all did very well. They were all collegial, worked together, and you can see that in the publications, in the abstracts, all of the fellows are represented because they all cross-train and help each other out. And you can see that my name is not first and my name is not last, because that was not my role. My role was to engineer the collaboration and not necessarily to take credit for the work being done. So that answers that part. But in terms of how do we mentor more people, more minority people into the system that can get into academic medicine, that's a big challenge. I got a grant from the NIH, it's $10 million. That was 2 years ago, and that was exactly to do that. It was to create a mechanism by which we can allow pipeline development, training, eventual recruitment into postdoc positions, and hopefully we can get some of those who are really very interested in academic medicine recruited into Downstate. That was the main goal. And we have several parts, and they are all, small things, but they all add up. One of the small parts is that we are engaging Mega Evers College in Brooklyn to take some of their, very brilliant students into our graduate school. Through that process, if they're able to finish their PhDs, we would actually retain them as postdocs at Downstate, and eventually they will become, academic. They'll get into academic medicine, begin to have their own careers in research and all that stuff. And another one is trying to engineer within the Downstate campus itself all the various silos of research, trying to bring together all the various research groups into a monthly research forum where people can share research ideas and build teams, and eventually, hopefully, something will come out of the teamwork, and then they can go for NIH funding. And a whole 2 other programs within that project. The NIH has this money. They are called endowment awards. In New York State, we have it. Another, I think SUNY Albany has it. Albany has the endowment award. I'm not sure of another program that has the endowment award from NIH. But those are the efforts that we are doing on our side to improve that.
Thank you. Thank you again. Thanks to the 4 of you. Wonderful mentoring, wonderful work by ECRIP trainees. Thanks for